It increases in anaerobic metabolism, so in ischemia you're going to see an elevation in lactate. You're going to see it also in tumor necrosis. You're also going to see it very markedly elevated in radiation necrosis. So when you have a patient that has been treated, one of the ways for us to try to differentiate between active tumor and radiation necrosis is going to be using a spectral analysis to look at the amount of lactate and the amount of choline. If you're dealing with a tumor, you're going to see elevation in lactate and elevation in choline. If you are dealing with radiation necrosis, you're going to see elevation in lactate, but the peak for choline is going to be suppressed because there is no cell membrane production. Aggressive tumors typically are going to be marked by an elevation in choline. If you only remember one thing out of this stuff, is that, okay? Choline is the marker for aggressive cell membrane production, which typically is going to correlate with aggressive tumors, okay? Cell membrane destruction and necrosis, lactate. So here we have this brain abscess. Brain abscess is going to have a lot of debris inside the cavity, which is going to typically give you a very high lactate production. If your voxel is within the abscess, then you don't have any cells there that are neuronal in origin. You're not going to have N-acetyl aspartate. And because there is nothing going on there but debris, you don't have a metabolic marker. So an abscess typically is going to give you a dominant lactate peak, which is recognized by a double peak. Like we see here, for example, like the bishop in the chess set that has a double peak at the top, okay? In a tumor, you're going to have lactate elevation, lipid from necrosis, and look at the choline peak here. Okay, so very high choline peak, much larger than creatine, and typically 2 to 3 times larger than N-acetyl aspartate. That's a marker for tumor. If that tumor also has lactate and lipids, you are dealing with a grade 3 or grade 4 glioma. Okay. So lipids are marked at 0.8 to 1.4 parts per million because there's a very large variation in those lipids as they are broken down from the cell membrane. The peaks are made up of unsaturated fatty acids, and it is a reflection of the necrosis and the rupture of axonal myelin sheaths and cell membrane. Increased lipids are going to be elevated in tumors, in necrosis, but also in tuberculoma. So elevation of lipids in a nodular enhancing lesion in a patient that has tuberculosis is going to be consistent with the tuberculoma. Toxoplasmosis, abscess, central pontine myelinolysis, and these myelinating conditions all are going to have breakdown of myelin. Breakdown of myelin, elevation in lipids. Okay. This is basically the same thing we've talked about, the different metabolites that we have and the corresponding chemical shift position in parts per million on that graphic representation, and then what each one of them mean. N-acetyl aspartate, neuronal marker, creatine, phosphocreatine are going to be energetic system, choline is going to be related to cell membrane health, myoinositol related to white matter, myelin sheath. Lipids is an indicator of cell rupture, lactate, anaerobic glycolysis. Glutamate and glutamine, these are excitatory neurotransmitters that are going to be abnormal in certain conditions. So this is a very detailed ability for us to map out different pathologies. pathology, because depending on specific metabolites that are abnormal, you can actually be able to tell specific conditions in the brain. Okay, so this is a very powerful technique, and we're not doing it justice in 45 minutes, but I'm just trying to give you an idea of how what the potential is on this technique. So how we apply this on our clinical realm, we're using it in a very narrow fashion. We're trying to sort out different specific clinical questions that this technique helps us with. Like, for example, are we dealing with a brain tumor, or are we dealing with post-radiation necrosis? And this is a very big problem in neuro-oncology, because it determines if you're going to give more radiation to a patient if there is a tumor, or if you're going to be treating the patient with steroids and conservative management if this is radiation necrosis. And you can injure somebody really bad if you make the wrong decision. So evaluation of tumors is very important. It's a very important application of MR spectroscopy. Evaluation of infarcts, evaluation of infection, multiple sclerosis, patients that have different expressions of HIV. So all of these types of pathology, the extra dimension of metabolic information helps in the differential diagnosis. So on brain tumors, we can extract information that helps us in tumor characterization, in the extension of tumor beyond the area of contrast enhancement. This is important in terms of how this patient is going to be responding to treatment, where to biopsy, for example, and what the prognosis is going to be. Primary tumors versus metastases, how to differentiate them. The primary tumors are going to have surrounding tissue infiltration that you can see on MR spectroscopy, while the metastasis is going to have a short transition between the tumor and the displaced normal neural tissue. Follow-up of response, of treatment response for tumor surveillance. So what we look for is the decrease in N-acetylaspartate, accumulation of lactate, elevation of lipids. This is all going to correlate with the degree of aggressive behavior of the tumor. And again, you're going to be looking for the N-acetylaspartate at 2. That's the first step whenever you're going to be looking at a spectrum. Find 2 parts per million, identify N-acetylaspartate, look and determine if that peak is normal or not, and compare it with creatine, which is at 3. So 2 and 3 are going to be your first points to look at, and compare those two. If N-acetylaspartate typically is going to be between 2 to 2.5 times the creatine peak. Okay, if that is smaller than that, then you have suppression of N-acetylaspartate. Choline typically is smaller, it's like 0.7 or 0.8, the height of the creatine peak. If it is elevated beyond that, then something is producing cell membranes at a higher rate than normal. Okay, so that is an indicator of neoplasm. Okay, presence of lactate and lipids is always pathologic. So if you're seeing peaks in 1 part per million to 1.6 parts per million, then this is abnormal, and it's going to have a correlate in the lesion. So depending on how tall that choline peak is on brain tumors, is going to correlate with the degree of aggressiveness of the lesion. The grade 3 and grade 4 gliomas typically are going to be characterized by very tall choline peaks. The presence of lipids and lactate in combination with very high choline peaks is going to correlate with glioblastoma. The presence of high choline peaks but no lipid and lactate favors an anaplastic astrocytoma, which would be a grade 3. Okay, and the difference between the two in the clinical and the imaging findings is presence of necrosis. So everything matches the spectral behavior with the tumor behavior. So here we have this infiltrating tumor involving the central thalamus and basal ganglia structures, very large choline peak. Even though we don't see significant enhancement on this patient, the presence of such a very large choline peak with depression of your N-acetyl aspartate, it will favor, instead of a grade 2, you're going to be calling this a grade 3. Okay, so it makes an impact on your assessment. Here we have this irregular pattern of enhancement on a patient with a very tall choline peak compared to N-acetyl aspartate. 3 times the size or more than N-acetyl aspartate, you're going to favor a glioblastoma as your diagnosis. Okay, and typically on the exams they are going to show you this kind of very clear differences. It's not going to be subtle. Okay, so you're going to be looking 2 parts per million N-acetyl aspartate, 3 parts per million creatine. Compare those two. This is decreased. Compare then choline. Choline is much larger than creatine. Then compare choline to N-acetyl aspartate. This is 3 times or more bigger than this one. You're dealing almost 100% glioblastoma multiforme. Okay. So here you have. This is a medial frontal lesion, relatively well circumscribed tumor mass. We have a multivoxel spectra, and we're looking at the spectral box number 1. Spectral box number 1. And what we have here, 2 parts per million N-acetyl aspartate compared to choline. To creatine, it is significantly decreased. This is normally 2.5 this size. So this is decreased N-acetyl aspartate. Then look at choline, very large choline compared to creatine, and at least 2.5 parts, maybe almost 3 parts N-acetyl aspartate to choline. So this is a very aggressive tumor. Look at the MR perfusion, which we're going to be talking some more tomorrow. And this tumor has a very large capillary bed, which is represented by a relative cerebral blood volume that is very large compared to the normal tissue, which is this one here. So the normal tissue is referenced from the contralateral cerebral hemisphere at the same location that we are sampling on the affected side. Okay. So this is functional information. Okay, and we have these tools in our hands. And if we don't learn to use them, then somebody else is going to come and learn to use them and take it away, like happened with the cardiologists, like happened with obstetric ultrasound, okay? Like it's happening with neuro ultrasound, okay? So other clinicians are also interested in doing imaging, and in the real world out there, if you don't know your tools and you don't market them in your hands instead of somebody else's hands, you're going to lose that. Okay, so that's real life out there. You need to be aware of that and be ready for it. So here you have an example of another tumor, very large, aggressive looking tumor with very intense enhancement, edema, mass effect, shift under the pulse, compression of the lateral ventricles. So at all imaging lights, this